Optimizing Telehealth, the premium resource for evidence-based strategies to enhance telepractice today. Brought to you by the Telebehavioral Health Institute. Enjoy this excerpt from the latest episode. To access the full episode and to get your continuing medical education and continuing education hours, visit us at Telehealth.org.
Hello, I'm Dr. Marlene Maheu, and I'm delighted to welcome you to the Optimizing Telehealth podcast, where you can participate in collegial discussion with interprofessional telehealth thought leaders from around the world. Let's talk a little bit, Alison, about which client or patient-specific factors contribute to telehealth success in the literature.
We have very good research in the field to show that telehealth works across different diagnoses. We used to say early on in this field, well, if a person is psychotic, or if they have this or if they have that, now it's widely recognized. Really, any patient, it can be appropriate for any patient. It depends on that specific patient and also on your own skills and scope of practice. Having said that, there are some things that can make it easier or more challenging, and patient comfort or familiarity with using technology is definitely a factor. And I recommend just being very transparent with people, like, how comfortable are you in this setting? Is there anything I can do to make this more comfortable for you? Or do you feel you have the skills to do this? And we're all learning in this environment. Cognitively, I actually do a fair bit of work with clients who have intellectual impairments and also with very young clients. And I wouldn't say there are any absolute barriers. It's about preparing an individual to be able to meet the needs of their assessment. And sometimes that involves bringing in other care providers to help them at their local site. Sometimes it's not seeing them in their home, but seeing them in another clinical setting. Current psychological status, I think that's probably where we most get into. Is it appropriate at this particular time? And often we're thinking about safety. Can we meet the safety needs of the client? And around substance use, I would say that is one area that for me raises more of a flag. We don't want to present barriers to care. So if we can see someone at all, I think that is important, but to also recognize there are limitations. It's much more challenging to tell if someone is intoxicated or withdrawing from substances, as an example. And that's one of the limitations that's often cited in the literature.
I agree. Many issues that we experience when we transition to telehealth from in-person care, we can find adaptions for, right? If someone has a sensory issue, such as being hard of hearing, we might offer a headset. We might use a whiteboard that we can share our screen through. Even with physical disabilities, I've worked with individuals who aren't able to sit up for a long period of time, yet we can position the equipment so that they can participate even from a hospital bed. So it's about thinking about how do we assess the individual personal needs of our clients and patients, and can we still reach that standard of care as we adapt to their specific needs? And I agree so much with what Alison said in terms of the substance use and abuse issues, because we know that there is a strong uptick in my state, I think nationally, in terms of access to treatment for substance abuse and substance use disorders. However, we also need to guide that treatment with ensuring that our clients and patients know that we can't treat them if they are under the influence of a substance while we are connected through telehealth.
And now we're getting to clinical conditions of populations where telehealth is indicated or contraindicated. So we'll talk a little bit about this. Alison, do you want us to get us started?
Yes, no absolute contraindications. You get to decide with the patient and client whether this is appropriate for them. And, part of that will be, I think we'll get better at figuring out what can be done, what should be done, and what is patient choice. Right now, over the last year, patients and providers haven't had as much choice because we've had to use telehealth. But as our systems mature and we start to go back to normal, we'll think about, does it work for this patient at this time? Can I do my appropriate assessment? And what is their choice? Right before the pandemic in our institution, we do a lot of telehealth. We do about 9,000 consultations per month. We had this discussion where we said, well, first time we see a patient, it can't be in their home. Well, and then the pandemic hit and we're seeing 9,000 patients a month in their homes. So so much of this landscape is changing. And a colleague of mine pointed out, it's way better to see somebody than not see them at all. Even, and he works a lot with clients who are acutely suicidal. So I think really anything goes. I would make the session as safe as you can. So making sure you have a contact phone number for the person, making sure that you know what their address is in case you have to call emergency medical services. So again, thinking of contingencies, but in general, no absolute contraindications, including in terms of diagnosis.
One of the things here is safety planning. And I think that is pretty important too with regard to the setting, because like you said, Alison, they might be in a home, but maybe they're alone in the home, and that's different than if there are other people in the home. So knowing who's there, who's accessible, will you allow them into the session? Will you not? To be really clear about your policies ahead of time, and then not just wing it as you go. If somebody is in a jail cell or a locked ward, then telehealth is very different. And you can work with people that are floridly psychotic or actively suicidal. But if they're at home alone and they're actively suicidal, well, now there's a whole other problem. Diagnosis is a big issue, but setting, frankly, is just as big an issue. And if you stop and think about telehealth, all of telehealth is about changing the setting. So I haven't seen enough literature addressing the setting. As people are trying to get involved with this, it's as if everybody understands that. But without some direct conversation about it, then I think we're kind of missing the point about safety planning.
Oh, Marjorie has an interesting experience
You
about.
want to take it, Alison? Yeah.
Sure. So, Marjorie, you're sharing that you had a patient who was 10 years old, and one of his diagnoses was internet addiction, and you were wondering about appropriateness of telebehavioral health for that person. Again, I think it depends. Someone who's 10, I would be thinking in a client like that, what are usually their triggers for using the internet? Can that be separated out from a session? Can, it be like a device that's only used for the telehealth session, for example? Could a parent help manage that? And does the person have impulse control? Certainly, lots of 10-year-olds don't have great impulse control, but for older clients, do they have impulse control? Can they separate their addictive behavior and the triggers for that and the settings for that? Can they delineate that from your appointment? And that might be a case where I would also think about a more supervised site, like a clinical site for that person, if that's a possibility in your practice. But again, it's just so individual.
I agree. I think if somebody thinks about, let's look at the AA model, an absolute, no alcohol model versus moderation training for alcohol, there's really two different ways to think about it. Whereas, people in moderation training learn how and when to do moderate drinking. There may be a model there that you can look at, Marjorie, in terms of, because it's kind of tough to deny a 10-year-old from any internet contact.
I've had questions come in regarding patients who experience psychosis and believe that they speak or interact with people on the TV. And then is telehealth appropriate? And again, we assess that individual by individual and how much insight do they have into their symptoms. I've provided treatment to individuals who suffer from psychosis with that exact symptom, but if they have insight into when they are hallucinating and when they are in contact with someone, then treatment can still be appropriate.
Thanks for listening to this excerpt from the latest episode of Optimizing Telehealth, your premium resource for evidence-based care. To access the full episode and to get your continuing medical education and continuing education hours, go to optimizingtelehealth.org.